We have been discussing about the vascular part of the general surgery in the past couple of lectures, and it's not about the arteries only, which are actually making up the vascular system, but the venous system as well and the lymphatics as well. In the past couple of lectures, we discussed about the arterial system and all the pathological processes and the diseases which are related to the vascular system, and obviously about their surgical management, particularly the peripheral vascular disease and the gangrene, which ultimately ends up in amputation. There's another system which is actually the venous system, and the arteries are meant for delivering the blood to the whole of the body, and the veins, they actually collect the blood from the different parts of the body, and then they come into the right atrium of the heart, then goes to the right ventricle, and through the right ventricle, by the help of the pulmonary artery, this deoxygenated blood actually goes into the lungs. There the oxygenation takes place, and by the help of the pulmonary veins, that comes back into the left atrium and then the left ventricle, and through it comes all the way to the arch of aorta, and then there are descending part of the aorta, and there are different vessels in the branches which are coming from the aorta and actually delivering the blood to the whole of the body. So, but there's another system which is actually the lymphatic system, and if we particularly talk about the the venous system. So the venous system is actually meant for draining all the deoxygenated blood or the blood from the tissues back into the heart and goes to the lung for oxygenation. But other than the arterial and the venous system, there's another system which is also very much important, and that is the lymphatic system. So all the basically the lymphatic system is actually compromising of the the lymphatic channels, the lymph nodes, and they actually they're meant for draining the lymph from, because it's somehow the waste matter and the growth factors, the interleukins, the cytokines, they actually have to be drained. So this is actually the there's an extracellular compartment, and there is the intracellular compartment, and there is the capillary pressure as well, and there is the interstitial fluid compartment. So if we talk about the interstitial fluid compartment, so the most of the time there are most of the waste matter which are being collected in the interstitial fluid, and if there's a high hydrostatic pressure and the low oncotic pressure, the flow of the fluid would be from high pressure to the low pressure, that at high hydrostatic pressure to the low oncotic pressure. So if we particularly talk about the function of the lymphatic system, it's actually collecting all the the waste matter which is compromising of carbon dioxide and the other cytokines and the growth factors. So it actually drains the whole of the waste matter, and by the help and all of the this lymphatic, the channels, they run along the arteries, and they ultimately drain into the the thoracic duct, which is an important larger duct which is present on the right side, is actually draining all of the lymphatic. So if you could appreciate in this diagram, so let me just label it for you guys, and then I'll be telling you in detail the part of the tonsils. These are the adenoids. Adenoids, they are actually the part of the lymphatic system. The tonsils, they're again the part of the lymphatic system. And even when there's any pathology, there is the infection going on, there's enlargement of the lymph nodes, right? So this is the right lymphatic duct which is entering, which is basically the thoracic duct. You can see the axillary lymph nodes. The main important part is the thymus, And we all know that actually the B cells and they're two important things, the thymus and the bone marrow. So these lymphocytes, the B cells and the T cells. So the B cells, they are actually formed in the bone marrow, and the T cells, they are actually formed in the thymus. So you can see the spleen, thymus, the bone marrow, they are actually the hematopoietic cells, and they're responsible for the formation of the lymphocytes. So particularly, bone marrow is producing the B lymphocytes, and the B lymphocytes ultimately, they make the plasma cells, and out of the plasma cells, these antibodies are produced. And if we talk about the thymus, so they are most commonly and most importantly, they're making up the T cells or the T lymphocytes, and these T lymphocytes, they are also important in the cell-mediated immunity. So we have two types of immunities. One is the antibody-mediated immunity, and other is a cell-mediated immunity. So the bone marrow is producing the B lymphocytes, and B lymphocytes then producing the plasma cells, and then the plasma cells are actually making up the antibodies. So they constitute a part of the defense system, which is the antibody-mediated defense. And the other one, the thymus. So thymus is actually making up the T lymphocytes, and it is actually constituting the cell-mediated immunity. So there are two important systems to combat the whole of the process of the infection or the disease and pathogenesis. So actually, the cell-mediated immunity and the the antibody mediated immunity. So if we talk about this, actually these are the lymph vessels. The whole of the body is actually constituting a whole of the lymphatic system, like that of the arterial system, like that of the venous system. So actually they run just along the arteries where there is a vein, along the artery, and they're compromising the three important constituent of the vascular system. So actually, if you could appreciate in the diagram, these are the lymph nodes, and they are present along all the important structures and all important organs and viscera in the body. So you can see that these are the lymph nodes actually, and they are connected to one another through the lymph channels. And ultimately, that if the veins and the arteries, they have a kind of a bi-directional flow, but the lymphatic channels, they have a unidirectional flow, like obviously the lymph is flowing from downward to upward actually. So the lymph travels along this, actually it's draining. If we particularly talk about when the plasma cells actually deliver the nutrients to the tissues, then most of the cells, the plasma is retained to the venous system. But some of the clear fluid, which is left behind, is drained by the lymphatic channel. So these lymph nodes, they're connected to each other through the lymphatic vessels, and they ultimately ascend upward, and both of them, they drain ultimately on the right side. There's a right lymphatic duct, and which is the thoracic duct, and the left side is draining into the subclavian vein. So actually, this all returns to the venous system, and ultimately it again becomes a part of the circulation. But a clear fluid, which is left behind of the plasma, comes to the lymphatic channels. The lymph nodes actually, they are responsible for the drainage, and through the lymphatic channels, ultimately they send upward, going to the subclavian vein in the thoracic duct in the neck. So the thymus and is particularly important for the generation of the T cells, and this is the lymph node, which is along every important structure, and the viscera, which are located inside, either in the chest, the mediastinum, the abdomen, and the perineum, they have associated drainage, and these ultimately drain the lymphatic channels into the major venous system which is present in the neck. So actually, these are the small magnified view of the lymph nodes. So actually the cortical areas, and these are the lymphatic channels, and the direction of the lymph in these channels is usually, most of the time, it's a unidirectional flow. It's not a bidirectional flow, just like the veins and the arteries. So you can appreciate these are the tissue cells, these are the lymphatic channels, and these are the interstitial fluid. What important role interstitial fluid has to play in that, I'll be discussing it in the next slide. You can appreciate this is the interstitial fluid, and there's a lymphatic capillary. So there's a capillary pressure as well, and there's a pressure which is present in the interstitial fluid. Now, this mechanism is important when we are going to discuss about the lymphedema, which is our primary focus or the primary topic of today's discussion, right? So we'll be, if you could appreciate in this, the physiology and the whole of the connection of the lymphatics with the arteriovenous circulation, then you can see actually this is the lymph capillary, and this is the flow of the lymph through the capillary. This is the lymph node, and these are the large lymphatic vessels, which has the valves, and ultimately they are becoming a part of the venous system, and the whole of the lymph is actually drained into the veins that contain a low pressure deoxygenated blood. So at one end you can appreciate this artery, and arteries they contain the oxygenated blood, and the oxygenated blood is a high pressure blood. So actually what happens is, like, the arteries, they are actually meant for delivering the blood to the tissues. So the tissue fluid with oxygen in the food passes out of these capillaries, and they ultimately comes to the tissues. And most of the the fluid, the deoxygenated blood that goes down to the veins, but the plasma, which is left with a clear fluid, which is particularly the lymph, that is drained into this capillary system, right? So this lymphatic capillaries and rest of the tissue fluid with cell waste, they enters into the venous system, which is the deoxygenated blood, right? So this is a very simple diagram. It will help you understanding. On one side you have the artery, and arteries, they have the high pressure oxygenated blood. On the other end we have the veins, and they actually contain the deoxygenated blood with a low pressure. This is the tissue, and this is the lymph capillary, and ultimately it goes to the lymph node, and they're the large lymphatic channels which enter into the veins. So arteries, the tissue fluid with the oxygen in the food that goes to the tissues, and the plasma goes particularly the lymph that goes to the lymphatic capillary, and the tissue fluid with the cell waste products, they enter the capillaries, and ultimately they go to the venous system. And the tissue fluid with cell waste products enters the lymphatic system, and most of them they enter to the venous system, but the clear fluid containing of the waste, they actually come to the lymphatic capillaries, and they ultimately go to the lymph node, and through the lymph nodes are the large lymphatic channels, and they ultimately drain into the venous system. So sometimes if you talk about there are lymphatic channels, and sometimes there's an infection in these channels, which is called as acute lymphangitis. So if we talk about the acute lymphangitis, the infection of the lymphatic channel is particularly called as lymphangitis. So most of the time, the causative organs behind this is Streptococcus pyogenes and Staphylococcus aureus. Most of the time, they are the part of the normal flora of the skin, and sometimes because whenever they're draining the tissues, they get entry into the skin, and ultimately, the Streptococcus pyogenes and Staphylococcus aureus, they are meant for developing the acute lymphangitis. So if you could appreciate in the diagram above, there's a streak, there's a kind of a boil which is present in the skin, and you can see these purplish streaks of the lymphatic channel, and the redness is spread along the whole of the lymphatic vessel. That actually, this typical sign of the acute lymphangitis. So most of the time, the lymphangitis is caused by the Streptococcus pyogenes and Staphylococcus aureus, and there's already maybe a skin infection, or maybe the infection already within the organ, and these the bacteria, they travel to the lymphatic channels as well, and they cause the acute lymphangitis. So in case of the treatment for the acute lymphangitis, most of the time, aggressive fluid therapy, elevation of the limb, and proper antibiotic therapy is somehow very, very much important. Sometimes even if you are giving the patient antibiotics for 48 hours and there is no improvement, or the patient is not responding to the antibiotic cover you're giving to the patient. So in that case, always remember, send the blood cultures and give the appropriate antibiotic therapy, because if the patient is not responding to the antibiotics you have already started for the 48 hours, then that means that the infection is resistant to that. The organism is particularly resistant to that that antibiotic, whatever you are given. And their limb rest has somehow very, very much important, and good fluid resuscitation and a good fluid therapy. So part rested and elevated intravenous antibiotics, they are the mainstream stray of the treatment when you are treating a case of acute lymphangitis. There can be some complications related to the acute lymphangitis, even when it's not treated in a better way or the effective way. Then the patient can develop, there can be recurrent attacks of the infection. There can be lymphoedema, because obviously whenever there's infection, there's a pooling, all the signs of the infection, rubor, calor, dullor, and obviously there would be redness, there would be pain, there would be edema because of the inflammation. So this edema actually, there would be stasis of the lymph, because obviously the infection will, there are some tiny valves which are present in the lymphatic channels. So what happens is when there's a focus of the infection, the tissue is already inflamed, there's edema, then the competence of these valves would be affected. And because of that, the flow of the lymph would be affected. There would be stasis of the lymph with a high increase of the protein, but with a normal net capillary pressure. So obviously that will lead to the lymphedema. So you have to not only treat the acute case of the lymphangitis, but you ultimately have to treat the complications as well, because when you are not competent enough and you do not treat the lymphangitis in the appropriate way. So what is important in case of the acute lymphangitis? The patient is going to present to you with a pain. There would be a proper focus of the infection may be present in the skin, and there would be a streak of redness in the arm or anywhere else where would be the infection, that's showing about the dilatation of the lymphatic vessel, right? And antibiotic therapy, rest of the limb, elevation, they are all important whenever you're treating. And the appropriate use of the antibiotics somehow is very, very much important. And you have to look for the complications as well. So this was about the acute lymphangitis. There's another condition of the lymphatic system, which is called as lymphoedema. And to be very honest, lymphedema is a kind of a very, very stressful condition for the patient, especially when it is in the advanced cases and maybe where the skin changes, and sometimes there's a lot of it can be a malignant lymphedema, or it can be a non-malignant. So in case of the malignant lymphedemas, there's ulceration and there's a lot of the infection and a lot of a foul smelly discharge from that. And it's very, very hard for the patient to live with such a condition. So it's not only a challenge for the patient, but actually it's a big challenge for the doctor as well and the treating surgeon. So sometimes the proper medical treatment, sometimes because it initially develops as a limb swelling, a swollen limb. So, and most of the time it is considered it's maybe considered as a DVT or the cellulitis or somehow, but because it remains mistreated and misdiagnosed most of the time, and the patient ultimately present to you with advanced stages with a lot of complication, dermatophytosis, and with the skin ulcerations, and the blisters, and this actual lymphedema spreads to the larger areas most of the time. It starts from the foot area, but ultimately it extends proximally. So before we go into the details of this topic, you should know what actually the lymphedema is and what is the pathophysiology behind all this. So actually the dilated lymphatic channels actually lead because of the ineffective drainage of the lymph or the stasis of the lymph with a normal net capillary pressure, but with a fluid that has increased proteins as compared to the interstitial fluid compartment, that is particularly called as lymphedema. So lymph is obviously the lymphedema is like the edema of the lymphatic channels. So because of the edema, there's a dilatation of the lymphatic channels, and it's not because of the changes in the net capillary pressure or the interstitial pressure, but the changes are because there's some problem with the drainage of the lymphatic channels with the normal net capillary pressure and high protein amount, or the percentage of the protein in the lymph is greater as compared to the interstitial fluid. So this is a typical picture of the lymphedema. Almost the right side of the foot has developed the lymphedema, and it's like usually the lymphedema actually starts from the most distal part and extend most of the time, and it is extending proximally, and it's involving the foot. It can be a unilateral involvement, it can be a bilateral involvement. So most of the time it's just starting from the foot, and normally there is a kind of a depression which is present on the malleoli, and you can differentiate the part of the ankle, right? So if you could see this limb and compare it with the normal side, you can see the lateral malleolus present here. You can see the medial malleolus present here. But if you could appreciate this picture, you cannot appreciate the malleoli on the right side. No lateral malleoli, no medial malleolus. So this is a typical sign, which is the kind of a buffalo hump. Because if you ever happen to see a buffalo, you can and if you ever observe or concentrate on the foot of the buffalo, so actually there's no depression or the gap which is present between the ankle and the malleoli and the foot. So actually that is lost because of a lot of the edema fluid. So because of that, it's a typical picture, and sometimes it extends to the shin and ultimately extends to the knee. So it can be primary lymphedema, it can be a secondary lymphedema. The primary lymphedema is most of the time, the cause is not known, and because there is somehow problem with the developmental channels, or there can be aplasia, or there can be hypoplasia of the lymphatic channels. You can say that if the cause is not known, then that's a primary lymphedema. If the cause is known, like maybe the parasitic infection or somehow some we'll be discussing the causes for that. So if the cause is not known, this is secondary lymphedema. So, but you should know the risk factors in the upper limb, you should know the risk factors in the lower limb. So if we particularly talk about the most of the time, the secondary lymphedema that develops because of the some kind of surgery to the lymph nodes, some kind of trauma to the lymphatic channels, some kind of radiotherapy, because it's actually distort, and actually there's the incompetency of the valves and the stasis of the lymph. They all lead to the lymphedema. So if we talk about the risk factors for the development of the lymphedema, and most of the time you can also, in your common observation, if there's a surgery to the breast or there's a surgery to the axilla and there's a lot of axillary dissection, then obviously most of the time axillary clearance is being done. So sometimes actually if the patient is not mobilizing the arm, then there would be stasis of the limb because you have already taken out most of the axillary lymph nodes. So that actually develops the this edema, because most of the upper limb lymph that is actually draining into the axillary lymph nodes, and when you have dissected the axillary lymph nodes, then obviously there would be ineffective drainage and there would be pooling, and ultimately there would be drainage of the limb. So that's how that's why it is always suggested that if the patient is being operated for mastectomy, either on the right side, the cannula, the BP, that should be checked on the left limb. No manipulation should be done on the right side because of the danger of the lymphedema. So number one point, the risk factor in case of upper limb for the development of the lymphedema, that is surgery with axillary lymph node dissection. Scar formation, fibrosis, radiodermatitis, they are, as most of the time after the trauma, that's a kind of the normal natural process of the healing. There's a fibrosis and there, but sometimes when there's extensive fibrosis, it ultimately affects the lymphatic drainage as well. So radiotherapy, drain, or the wound complications, axillary web syndrome, it's also the important risk factor for the development of the lymphedema. Seroma formation, most of the time when you do not put a drain in after post-operatively, most of the time in this in the organs in which you're performing, like the breast, like the thyroid, they have got a good serious production, and obviously they ultimately there's a formation of the seroma, and that leads to the lymphedema. Advanced cancers, malignancy, obviously obesity is somehow very much related. It's kind of the risk factor for lymphedema. Congenital predisposition, like running in the families, like the Tourette syndrome and some kind of the other syndromes, trauma, obviously, and chronic skin conditions, hypertension, they are all important risk factors you should keep in mind. Other than that, the taxane chemotherapy, the insertion of this pacemaker, AV shunt for dialysis, air traveling, endemic area for the lymphatic filariasis, they are, in one way or other way, the mechanism still remains the same. Some kind of damage to the lymphatic channels, or there is some kind of interference with the drainage of the lymph, that all lead to the lymphedema. So in upper trunk lymphedema, the most important cause is the trauma. The second most important cause is the upper limb surgery, particularly the mastectomy, the axillary lymph node dissection, radiotherapy, the advanced cancer, the chemotherapy, the taxane chemotherapy, some kind of the seroma formation, wound complications. You should remember these things whenever you are whenever you're encountering a case of the upper limb lymphedema. So there can be not only the upper limb lymphedema, there can be a lower limb edema as well, and there are some important risk factors which are related to the lower limb lymphedema, and particularly the inguinal surgery, especially if you're operating a case of the direct or indirect inguinal hernia, the femoral hernia. There's a lot of the dissection, and we have the inguinal canal, and the inguinal canal, the inguinal lymph nodes. So these lymph nodes, They are actually draining most of the lower limb, right? The deep with the superficial inguinal lymph nodes and the deep inguinal lymph nodes, and the superficial inguinal lymph nodes most of the time the drainage is, the testes and the testes goes to the parietic, but the scrotum is actually drained into the inguinal, superficial inguinal lymph nodes. So if there's interference with these, the surges involving the lower limb, there would be inguinal lymph nodal dissection that will lead to the formation of the lymphedema, post-operative pelvic radiotherapy, recurrent soft tissue infection at the same time, again obesity, advanced cancers, DVT, varicose veins, and like if you're performing a varicose vein stripping and vein harvesting, again the genetic predisposition, advanced cancer, orthopedic surgery, because most of the time, the orthopedic surgery develops the DVT. Most of the time the patient is immobilized for a very long time. Poor nutrition status, thrombophlebitis, chronic venous insufficiency, unresolved asymmetrical edema is another cause. Chronic skin conditions, Cochrane illness is also one of the factors which is causing the lower limb lymphedema. Immobilization, as it has somehow related to the orthopedic surgery, patient is immobilized for a very long time, and obviously there would be stasis, and ultimately there would be lymphedema. That's why after the orthopedic surgery, or most of the time after a prolonged surgery, the patient is still encouraged for a physiotherapy and at least some kind of the mobilization. So post-operatively, it is somehow very, very much important to immobilize the patient as soon as possible, as soon as he's fit for that, because it reduces the risk of DVT and obviously the chances of the lymphedema formation. And the endemic lymphatic filariasis, it's a secondary cause for the lymphedema. So this entire important topic we'll be discussing the organism behind for the pathophysiology behind the cause of the filariasis. So for the lower lymphedema, remember inguinal lymph nodal dissection, remember the orthopedic surgery, immobilization, varicose vein stripping, and the vein harvesting, the wound infection, genetic predisposition, advanced cancer. They are all important risk factors. So, so far we have discussed about what the lymphedema is and what are the risk factors or the causes, like the primary and the secondary lymphedema. Now, the most important thing to be discussed here is about the pathophysiology for the lymphedema. So, whatever the cause may be, whatever the risk factors are, whether it's a chemotherapy, it's a radiotherapy, it's a surgery, some kind of dissection with the lymph nodes, ultimately they all lead to the lymphatic obstruction. So whenever there is a lymphatic obstruction, the drainage of the lymph would be compromised. And whenever the drainage of the lymph would be compromised, there would be lymphatic hypertension and distension. And there would be accumulation of the interstitial fluid, proteins, growth factors, and obviously, because of this stasis, there would be, the proliferation of the bacteria, there would be increased collagen production, and ultimately the inflammatory cascade, the cytokines, the interleukin, the macrophages, the lymphocyte, obviously, they come into that place, and ultimately there is activation of the keratinocytes, and because of the activation of the keratinocytes, there is a protein-rich edema fluid, fibrosis, and ultimately there's a dermal thickening and proliferation. So whatever the cause, whatever the risk factor is, the key point is the lymphatic obstruction. It can be because of the advanced cancer. It can be because of some kind of radiotherapy to the lymph node. It can be because of the surgery or the dissection with the lymph nodes. It can be immobilization. So ultimately, they all lead to the lymphatic obstruction. So because of the lymphatic obstruction, there would be stasis of the lymph. Ultimately, there would be distension. There would be lymphatic hypertension and accumulation of the proteins and the bacteria and the interstitial fluid, and all of them will obviously lead to the increased production of the collagen And after that, because whenever there would be seeding of the bacteria, then ultimately there would be a defense mechanism of the body would be activated, and there would be macrophages, lymphocytes. They would be coming to that place, and ultimately, because of the inflammatory cells, there would be activation of the keratinocytes, and there would be protein-rich fluid, and there would be some kind of fibrosis, and there would be dermal thickening and proliferation. So remember the pathophysiology behind all this. So how, if a patient has already developed lymphedema, what kind of the symptoms he's going to experience, and what are the symptoms you are actually looking for? So the swelling, this is the main important complaint, and the patient will actually give you the history typically that he has developed a swelling for the past couple of days, or maybe 4 or 5, or post-operatively after the surgery. There would be constant dull ache pain, and sometimes when there would be a lot of hypertension, then the patient will complain of a severe pain, or there would be, vascular compromise because of the edema. Then there would be a severe pain, burning and bursting sensations, general tiredness and debility, sensitivity to the heat, pin and the needle sensation, because the edema will ultimately compress the nerves as well. So the first and the most important symptom would be swelling. The patient will give you a typical history of the swelling. He will give you a kind of a clue for the secondary lymphedema, like the infection, or, it would be post-radiotherapy, or it would be, with the most of the time related to the nodal dissection, the upper limb or the lower limb. He will be giving you the history about the chemotherapy or the advanced cancer. And he will complain about the constant dull ache pain, but sometimes the pain becomes very severe when there is impingement or entrapment of the nerves or vascular compromise. Burning and the bursting sensation, I'll say pin and the needle sensations, and again, pinprick sensations. Why? Because of the compression, or because of the entrapment of the nerves because of the edema fluid. So these are typical symptoms, and other than that, the patient can complain of cramps. There would be associated skin problems as well, because there would be dermatophytosis, dermal thickening as well. And because in the later stages, there's activation of the keratinocytes, and there's a fibrosis, and there is, some kind of skin problems as well, like eczema and the dermatophytosis, immobility leading to obesity and muscle wasting. There would be back pain and the joint problems. There can be athlete's foot, and there can be acute infective episodes. Not only the patient is, going to tell you that he developed the swollen limb, but sometimes they're hardening and their skin changes because there's a lot of extensive fibrosis. So because of that, there can be like dermatosis, and there can be dermatophytosis along with the swollen lip, and you have to investigate all these things. So we actually classify the lymphedema into two important categories: the primary lymphedema and the secondary or the acquired lymphedema. So the primary lymphedema is actually because the cause is not known, or maybe there is some kind of the development or errors, like the hypoplasia or the aplasia of the lymphatic channels. It can be congenital, or it can be familial or sporadic. And the secondary causes, obviously, they include the parasitic infections, the fungal infections, filariasis, some kind of surgery to the lymph node, nodal dissections, right? Radiotherapy to the lymph node, chemotherapy, advanced cancers, malignancy. They are somehow, and if we talk about the tumors, the malignant tumors which are related to the lymphedema is a lymphangiosarcoma. They can be Kaposi sarcoma, they can be basal cell carcinoma, or they can be squamous cell carcinoma. You should keep these things in your mind. So there, other than classification, there's a staging of the lymphedema: stage 1, 2, 3, and 4. So in stage 1, there's no clinical evidence of lymphedema. Like if you could do a Doppler scanning and you look for the lymphatic channels, then there would be dilatation and there would be increase of the interstitial fluid. But clinically, there would be no swelling and there would be no lymphedema. So this is stage 1. In case of stage 2, if you try to if you try to press the part of the lymphedema, there would be depression or there would be pitting. So if there is pitting, so this is stage 2. In stage 3, if you try to press that skin, the skin is so hard and there would be no pitting. And in stage 4, there are skin changes as well. So in stage 1, no clinical lymphedema, but neurological evidence of the lymphedema. In stage 2, their pitting is present, like this tremor sign. This is called as a tremor sign. When you try, there's a lymphedema and you try to press it, and there's a pitting, then this is stage 1. And in stage 2, sorry. And in stage 3, this tremor sign is positive. In stage 2, this tremor sign is negative, but in stage 3, this tremor sign is positive. So in case of that, you try to press that skin, but the skin is already so fibrous and there's dermatitis and dermatophytosis, then obviously hardening of the thin, there would be no pitting. And in stage 4, there would be associated skin changes and skin ulcerations, as you could appreciate in the diagram. Again, this is a lymphedema in the lower limb. Again, it's the same like stage 1, 2, 3, and 4. In stage 1, there's no clinical evidence of the lymphedema. In stage 2, obviously there would be the pitting would be present, tremor sign would be negative. In stage 3, tremor sign would be positive. There wouldn't be any pitting when you try to press the limb with a finger because of the hardening, thickening, and dermatitis. And in stage 4, it is the advanced disease. You can appreciate it's a kind of the buffalo leg or the buffalo hump, and you cannot appreciate the medial and the lateral malleoli, and obviously there are associated skin changes as well, like the dermatophytosis. Another important thing is to determine the severity. So in case of the mild disease or the mild lymphedema, there is less than 20% of the increase in the fluid volume. And in moderate, there is 20 to 40% excess lymph volume. And in severe cases, they're greater than 40% excess lymph volume. This is somehow if there is greater than 40% excess lymph volume, then obviously that would be the advanced stage and there are more chances of the cancer, and obviously the treatment would be difficult in such cases. There's some malignancies which are related to the lymphedema. I have already discussed a couple of slides back, but I'm going to repeat it for you guys. Lymphangiosarcoma, Kaposi sarcoma especially, which is in the immunodeficiency states, like the acquired immunodeficiency syndrome and because of the human immunodeficiency virus. Squamous cell carcinoma, liposarcoma, malignant melanoma, and malignant fibrous histiocytoma, but most commonly lymphangiosarcoma and Kaposi sarcoma and the squamous cell and the basal cell carcinomas. These are more of the malignancy which are related to the lymphedema. There can be lymphoma as well, but that's kind of the less common. Basal cell carcinoma, squamous cell carcinoma, Kaposi sarcoma, and lymphangiosarcoma. These are some important malignancies which are related to the lymphedema. So, whenever a patient is presenting to you with a swollen limb, there's some kind of differentials which are coming into your mind. They can be non-vascular or lymphatic, or they can be vascular. So there can be general diseases like because of the cardiac failure, because of hypoproteinemia, because we know that if there's deficiency of the proteins, there would be high hydrostatic pressure and the low capillary oncotic pressure, and because of that there would be generalized edema. Hypothyroidism, allergic disorders, prolonged immobility. Then if we talk about the local disease processes, then there could be cellulitis, there can be ruptured Baker cyst, there can be myositis ossificans. It's a kind of the inflammation which is related to the muscles, bony or the soft tissue tumors, arthritis, hemarthrosis, Capsule hematoma is also important. Achilles tendon rupture is somehow a localized cause for the swollen limb. If we talk about retroperitoneal fibrosis, there can be arterial, venous, and lymphatic abnormalities. There can be gigantism, like most of the time. This is rare, but it usually affects all the tissues. Drugs like corticosteroids, estrogens, progesterone, they actually also leads to the development of the swollen limb and a kind of the differential in case of the lymphedema. And there can be monoamine oxidase inhibitor. There can be trauma, which is a kind of a painful swelling due to reflex sympathetic dystrophy, or there can be obesity, right? So broadly, we classify if we talk about the differential diagnosis that should come into your mind, like the non-vascular lymphatic, the general causes, the localized causes, the general cause, obviously, the renal failure, the cardiac failure, liver failure, hyperproteinemia, hypothyroidism, allergic disorders, prolonged mobility, local disease like the cellulitis, ruptured Baker cyst, Achilles tendon, arthritis, hemarthrosis, trauma, drugs, gigantism, they should all, come into your mind. Lipodystrophy, lipoidosis, they're also the differential diagnosis. And in case of the venous causes or venous differential diagnosis which are coming into your mind is that obviously the most common, the deep vein thrombosis, and there would be always predisposing factors like the orthopedic surgery, prolonged immobilization, long-standing conditions, or classic signs and the pains would be present. There can be post-thrombotic syndrome, there would be swelling, there would be venous skin changes, there would be venous claudication. Varicose vein, I'll say they're less significant when there is a leg swelling, but you can actually perform some of the tests in a Doppler venous ultrasound. Klippel-Trenaunay syndrome, which is rare at birth, but there is abnormal lateral venous complex. There would be capillary nevi, which can be present. There can be bony abnormalities, and there can be hypoplasia of the veins. And there can be external venous compression, like there can be a tumor, the pelvic or the abdominal tumor, and there can be ischemia reperfusion, like falling lower limb, revascularization. There can be reactional edema. So always remember, if we talk about the differential diagnosis, they're non-vascular and the vascular. We discussed the non-vascular in the previous slide. Now talk about the vascular. The most common, the most important is the DVT. There can be varicosities. There can be post-thrombotic syndrome, and there can be some kind of external compression like the pelvic tumor. And if we talk about the arterial differential diagnosis of the swollen limb, there can be AV malformation with localized or generalized swelling, and there can be aneurysms, the popliteal femoral or Fell's aneurysm, which is usually associated with the trauma. It's a kind of the iatrogenic injury. So these differential diagnoses should come into your mind when you are discussing a case of the lymphedema. We'll be talking in the next lecture in detail about the primary and secondary lymphedema. So that's all for today. Keep watching sqadia.com.